Yeah. Am I being too cruel? Or you want to suggest your friend? Don't point your friend. Just point out your friend, then I will go there. If not, we'll ask the panel, unfortunately. So, Professor Thảo, will you use and PPI?
In this case, I won't choose because with because we know this case has finished the adjunctive examination, so the functional treatment is sure. So if we treat all of the disease overlap with one reasons, it may be not the acid reflux data. So utilize with refractory of the first choice.
Thank you very much. That is the answer that we want to hear. Second, what is the, I still have a presentation later, so I have to make it a bit quicker. What is the role of a low format bias CBT and gut-directed chemotherapy in the management of IBS-D and FD? Yes, there's a role. Already finished. All right, Shri.
Can I ask a question? So, the cognitive behavioral therapy and gut-directed hypnosis is a very Western approach to this. So my question here is, how common are these therapies used in Asia? How well accepted are patients accepting of these therapies?
So in Singapore, then the first thing first, even before all these behavioral therapies, education is very important. Sometimes just talking to a patient about this may be a post-infectious or post-antibiotic problem. It helps for patients to understand what is going on. And then if you have more than 5 minutes in your clinic, then normally I'll ask, how is your sleep? This is the way to try to throw a stone whether the patient is ready to discuss their psychological problem with you. But yeah, you're right. A lot of us don't have the luxury of having a psychologist. And those of you who like to see patients, maybe maybe have a counselor in you that like to help the patient. But maybe we'll throw this question to Professor Du in Vietnam. How do you deal with this problem?
Yes, regarding to the first question, I would like to mention about rifaximin first. I think that as I told our panelists already, it's a very expensive drug, and in my opinion, I do not use it as the very first treatment. And for PPI, I think that we should consider about the use of PPI in this patient and not to take it too long, because you are already mentioned about post-infection, IBS maybe, so microbiota is also issue. So my preferred approach here is the prokinetics and TCA. And regarding to the role of low FODMAP diet, the issue that Linda mentioned is a big problem in Asia because we have a variety of good food, especially in Hanoi, and we also have a wide variety of ingredients. Like I mentioned that pho in Hanoi and pho in Ho Chi Minh may be different ingredient, and it's very important, and I think that it's very challenging for our patient to follow that, and we do not have the evidence that show the patient can compliant with our therapy. So I think that's a very important story, but we need time to resolve it, and in my opinion, I think that it should be the last resources that we should consider.
So regarding that question, Linda, in Asian subcontinent, this CBT and gut-directed hypnotherapy as such limited availability, and people are physicians are not doing, gastroenterologist also. But I will share my experience for last 3 to 4 years. Whether you can call it CBT or gut-directed hypnotherapy, I'm using both these things as in yoga. Yoga is a discipline where you can target this gut-brain interaction. So in my experience for last 4 years, what I am doing in this group of patients, you can relieve constipation with it, you can have this CBT, behavioral therapy for dyspepsia, and it is quite useful in this approach. I am seeing day-to-day practice and trying to generate evidence, and few things have been done, and lot of more things has to be done.
A question of my own. How many of you have more than 10 minutes in your first visit training? Good. Please put up your hand, just want to see. How many of you have more than 10 minutes? First visit clinics. Really? More than 5 minutes? Alright. So that's a problem. I was just asking about, I was hoping 10 minutes, 20 minutes, then we get more and more hands. But actually it stopped at less than 10 minutes. So we actually don't need to talk about all this. And that's the problem. I'll show some data after, but a good consultation with all this story, you need more than, really more than 10 minutes for consultation. If not, it's just won't work. And that's our problem, at least in a lot of the Asian countries, obviously. And you don't even have time to take even a simple dyspepsia history, not to say about overlap history and stuff. And I think that is something that we all need to work about, because 10 minutes is just not enough for first visit. But let's continue. Which neuromodulators are recommended in this setting?
Before that, maybe I can summarize for the audience, because
right.
we are not doing simultaneous interpretation. Vừa rồi thì hai câu hỏi đầu tiên thì các bác sĩ có trao đổi một chút về việc là mình có hay không sử dụng PPI và rifaximin như là điều trị bổ sung, và thứ hai nữa là vai trò của các cái biện pháp khác, ví dụ như là cái chế độ ăn low FODMAP, các cái điều trị gọi là liệu pháp nhận thức hành vi và cái thôi miên. Thế thì các chuyên gia ở trên này thì có trao đổi với nhau, thì như từ phó giáo sư Bách Trọng Đức thì còn nói rằng là rifaximin thì sẽ là một cái điều trị rất là đắt tiền, và vì thế nên là nếu mà dùng cho bệnh nhân thì mình sẽ không dùng cái đó. PPI thì mình có thể xem xét mình sử dụng, nhưng tuy nhiên thì mình không nên dùng quá là lâu, bởi vì bệnh nhân này thì trước đó là mình nghĩ rằng cái IBS của bệnh nhân nó xuất hiện sau một cái nhiễm trùng, và vì thế nên là cũng phải cân nhắc về cái vi khuẩn đường ruột của bệnh nhân. Và vì thế nên là đối với phó giáo sư Đức thì cái tiếp cận điều trị trên bệnh nhân này sẽ là sử dụng prokinetic và thuốc chống trầm cảm 3 vòng. Thế còn cái vấn đề về chế độ low FODMAP, chế độ ăn low FODMAP thì đồ ăn ở Việt Nam chúng ta có rất là nhiều món ăn phong phú với các nguyên liệu và cách chế biến, và vì thế cho nên là để mà có thể mà thực sự tuân thủ cái chế độ ăn này cũng rất là khó, và bản thân cái người bệnh người ta có tuân thủ cái này hay không thì nó cũng là một cái câu hỏi phải đặt ra, và vì thế nên là cái low FODMAP này nó sẽ là cái mà mình sẽ nghĩ đến cuối cùng. Và ngoài ra thì các chuyên gia cũng còn nói về những cái liệu pháp liên quan đến tâm lý. Thế thì để mà làm được cái việc đấy chúng ta cần phải có một cái đội chuyên gia tâm lý, những người biết làm CBT, và nó rất là tốn tiền, nó rất là đắt, và nó mất thời gian nữa. Thì ví dụ nếu mà mình thậm chí đến thời gian mình để mình tư vấn cho bệnh nhân về một cái hội chứng chồng lọc, về các bệnh lý chức năng tiêu hóa thì cũng chưa chắc đã là đủ thời gian để làm cái việc đấy, đừng nói đến những cái điều trị khác. Thì bác Manas bác lại có một cái là bác ở Ấn Độ bác có thể làm cho bệnh nhân tập yoga, ở đây cũng có thể là một cái cách để có thể liên quan đến vấn đề tâm lý của bệnh nhân. Okay.
It just sounds like when you say so many things. So which neuromodulator are recommended? We have Professor Kiva from Malaysia to answer that.
Hello, yeah, good afternoon. Okay, so for me, my approach when to which neuromodulator to choose will depends on the coexisting, overlap symptoms. For example, whether patient has diarrhea component or not, or they have constipation, or they have sleep problem or not. Let's say if FD with IVSD overlap, I guess TCA to me is the best, and because their side effects is like constipations, and they are big sedative effect as well. But having said that, I have to tell them that taking all this is not like instant effect. It will take up to 2 weeks. The side effects may be immediate. They have to tolerate on it. On another hand, if there's presence of like pain component, whether you want to choose, the component of SNRI with a noradrenaline effect, that can help the pain effects. Or if there's a patient with FD with some, weight loss, of course, after you have ruled out organic causes, you may want to choose mirtazapine or so. So it's like down to your case. You have to, choose your neuromodulator according to the patient. The panelists, the rest of you, any other comment? Would you do it differently?
Professor, what do you think is, are the doctors in Vietnam comfortable with neuromodulators, or are people very upset if you say, I'm going to give you antidepressant, and then they'll say, oh, I'm not depressed?
I think that the concept is changing. But the main I think that the main idea from most of our colleagues are antidepressant, just for the gastroenterologists. So we have a lot of conference, and we ask them and address that to change the definition to neuromodulator, so that we can easier to persuade our patient to use the drug. And also mention about the side effect, which will happen first before we have the benefit. Yes. So I think that we need to emphasize more.
Thank you. Now we have to translate.
Thank you. Còn câu hỏi thứ ba là câu hỏi sử dụng các thuốc điều biến thần kinh thì các chuyên gia có nói là đầu tiên thì mình sẽ phải xem là bệnh nhân của mình có những cái biểu hiện, những cái triệu chứng nào, chẳng hạn ví dụ như là tiêu hóa, triệu chứng tiêu chảy và chúng ta nghĩ đấy là IBS chẳng hạn, thì đương nhiên thì lựa chọn của mình sẽ là thuốc chống trầm cảm 3 vòng, và mình sẽ chú ý đến là có thể là bệnh nhân của chúng ta sẽ có một số tác dụng phụ của các thuốc chống trầm cảm, ví dụ như là có biểu hiện là sút cân thì có thể mình nghĩ đến mirtazapine. Thì có một câu hỏi rất là hay đến từ giáo sư Kevin, đấy là ở Việt Nam nhà mình thì có gặp phải cái vấn đề là nếu bây giờ mình nói với một bệnh nhân tiêu hóa rằng là tôi sẽ cho anh kê một cái thuốc trầm cảm, thì không biết là bệnh nhân người ta có phiền về cái chuyện đấy không, thì phó giáo sư Phan Trọng Đức có nói là hiện tại bây giờ thì mình cũng đang bắt đầu mình thay đổi cái góc nhìn đó, ví dụ như là có thể chúng ta đổi tên cái cách gọi cái thuốc đó. Không biết là giáo sư Đức có muốn comment gì thêm cho các bác sĩ dưới kia không?
Sorry, can we just a very short comment that as Professor John mentioned, that TCA should be a good option here. And besides the good effect on the pain, abdominal pain, the side effect here is constipation can help patient because the patient tend to be IBSD. So we use one drug, and we can use the side effect of the drug to help the patient, and it's no need to use multi-drug.
Thank you.
Thank you, and about 10 minutes to show you a few slides. So as we have said, it's actually quite common to people don't just see, patients don't just come in with a label, I have FD, I have IBS, they have FD, IBS, GERD, global, just like the case that was presented just now. They don't just have, they have FD, but they also have morbidity, but they also have constipations. So in Rome criteria, we used to put patients into bracket or name, but actually, the background of it is we did have research in Asia that looked at what are the kinds of diseases do we see, what kind of symptoms we see in Asia, and we found that actually a lot of patients don't have just one kind of diagnosis, they have double or triple, or they have multiple overlap of their problems actually. This is a study that was done in Asia, multiple countries, of a lot of people who are authors actually sitting here, and you see that there are, for example, people have anorectal pain, constipation, abdominal pain with diarrhea, meal-related bowel symptoms, and different things. They don't just confine with the Rome criteria. And also, another study was actually done in Australia, showed the same thing. There was more similar to the Asians' symptoms. So there was actually paper that started to editorial that was started to question, that is Rome burning. After that, obviously then Rome combined and come together with a working team and started to recognize the importance of overlap in disorder of gut-brain interactions. And I happen to be one of them. So if you criticize people more enough, then they'll include you into their party actually, so that you stop criticizing them. So just now we have obviously DGBI overlap. So you can have obviously overlap, for example, GERD and your bowel symptoms. Obviously, DGBI overlap with non-GI condition as well, like headache, migraine, and other things. Some of the diagnoses, the management of it is still a big problem because there's really no guidelines. A lot of you, obviously, because although we are saying that this is some new concept, but you have been doing this in your own clinic. So a lot of people obviously use symptom-driven, whatever is most disturbing your symptom. Normally, a lot of people will then concentrate on that symptom, but also use back your own criteria. They actually do have a framework for people to work on overlap in a way. So this is called a multi-dimensional clinical profile. So if you have more than 10 minutes in your clinic, then you can use this. So I think it's a bit useless, so I'm just going to jump. Because if you have more than 10 minutes, then you want to know, for example, what is the wrong diagnosis of the patient, whether there's any overlapping. Then you want to know what is clinical modifiers. Why? Because this will guide your investigations, whether it's related to food, whether it's post-infectious, whether it's more of a rating, more of a mood thing, or whether there are other factors. Why? Because they actually summarize a clinical modifier that associate with investigation and treatments for that patient. So if you have time, this is something clinical modifier that you should ask. But after that, then another area is what is the impact? Today, we have not been talking about a lot about impact, but obviously, if you ask how does your symptoms impact your life, does it stop you from going to school? Does it stop you from going to work? A lot of my patients actually stop working. Burden, and they only come after, yes, it comes worse. So this is an area that we have not been concentrating. And also psychosocial modifiers, anxiety, depression, abuse, these are all very important. But then again, we have less than 10 minutes. So these are all not going to work in your clinic. So, real world practice, yeah, better, because I know that, whatever they teach, it's not going to work because we only have 10 minutes. Even though, let's say we all have 10 minutes or even less, you still have to listen to your patients. Because he's telling you the diagnosis. Who said this? Kevin Seah said this today. Someone said this, someone more Sir William Osler said this is much more prominent. Unfortunately, study again and again shows that we are not listening. We often interrupt the patient. We ask pointed questions because we all act like we are in A&E. Do you have chest pain? Does the chest pain radiate to your neck? Do you have sweating? Do you have shortness of breath? This doesn't work with bloating. Do you have bloating? There's no bloating. You stop there because it just doesn't work. Medical students are taught how to take history for chest pain, but they are never taught how to take history for bloating. They just don't know where to go. And unfortunately, oftentimes, we cut patient short and we don't give the patient time to talk. Trust me when I say that, out of your 10 minutes, try to give your patient 1 minute to talk. See, I'm going to give you 1 minute. It feels very long. No? It's not so short actually. See again, it's quite long. So don't try to cut the patient. If the patient doesn't want to talk, you continue to type on your screen, or you continue to write. Give them time to talk. Don't cut them. Because they often tell you the story or the diagnosis. The 1 minute, normally not 1 minute, normally like 30 seconds. Look them in the eye. 30 seconds is what you need to structured listening. Patient can go round and round. All our functional patients, IBS patients, go round and round when they give the story, but you listen. And then you pick up the important things that patients tell you. You can use background aspect, how does it affect patients and stuff, and then set expectations. If you know that you only have 10 minutes, you tell them, today we will deal with this question, we'll deal with this problem first. What is your best weapon as a doctor for patients who don't want to go out of your room, who want to spend more than 10 minutes? There are two things actually. I would say, but don't quote me. I would tell my patient, well, I still have a lot of patients, wait until, let's collect what you want to think, let's wait outside first. I'll see you as the last patient again. I'll see you until no matter, if it's night, evening, I'll wait for you. Second thing, why don't you just come tomorrow again? Or come next week? Patient just want to see you. They want to make sure that their voices, their concerns are answered. If not, because they know that the moment they get out of your room, they lost you. So you give them a lifeline. Oftentimes, it's often that they cut shorts, but some the worst one they actually do wait for you and then you have to settle back. Oftentimes you ask them to come back early, and that is what patients want to hear. And just now we talk about a lot of multi-targeted therapy, trying to use, for example, just now we talk about carbohydrates and other drugs. And for example, these are the examples of things that agents that may have overlapping kind of DGBI efforts that you use, but there are also non-pharmacologicals. Obviously, just when we talk about diets, that's been used for IBS and IBD, and also this is sort of like evidence of low format for pharmaceuticals. You're going to hear a lot about this from Professor Victoria Tan tomorrow, and also psychological therapies that none of us have time to use. But the more important thing is, the 10 minutes that you have, hopefully in future, you have AI that help you to take history, listen to the patients, and give you a summary when the patient comes. Maybe, not today, but it'll come soon, hopefully. But the second thing is, why do we think we need to talk to the patient, listen to the patients, and have rapport with the patients? Because your treatments that you use is very different from the treatment that I give. Because my treatment has triple the effect of this. And this is very important in gut. If you don't have a good rapport, it doesn't work. So whatever overlap treatments you give, this is still the most important thing. And I think we need to stress again and again that recognizing overlap is the norm nowadays. No? Don't stop at once. It's not the exceptions. Thank you very much.
From DGBI.